Hi, my name is Brad Kropp, and I'm the medical director at OKC Kids Urology in Oklahoma City. Hopefully you've come to this app to try to learn more about bladder exstrophy, and this is really related to the newborn bladder exstrophy patient. We have an earlier video that we talked about the different complexes because it's an exstrophy complex, so we talked about bladder exstrophy, Epispadias, and cloacal exstrophy, and that's the way our app is broken down into those three disease complexes. We're really going to talk about the bladder exstrophy and the Epispadias kind of closure, so the initial surgery and the organs that are involved. I think it's really important as we start to educate ourselves about bladder exstrophy, and since you're brand new to this, I'm going to try to use the medical terms so that you become more familiar with them. I also want you to use this app and this video to understand, so you can ask your surgeons questions, about, hey, what do we need to watch for, kind of thing. So, obviously the bladder exstrophy is a birth defect. And again, there is no known cause. Moms didn't do anything, dads didn't do anything. You didn't sleep under an electric blanket or drink Diet Coke, that caused this to happen. It's just a rare event. And essentially what you had is the bladder should be like a round ball, like a football or a basketball, and it should be on the inside with the muscle of the abdomen and the skin of the abdomen over the top. And essentially something happens during that developmental process with the cloacal membrane, and that ruptures, and therefore all of a sudden the bladder pops out like a jack-in-the-box. It just opens up and opens up like a book. And then all the organs of the pelvis then become involved in the process. So I want to go through each organ that's involved, both males and females, for bladder exstrophy, because each one of these organs has to be surgically addressed or monitored in order to make sure that we try to get the healthiest situation in the future. So the first thing and the most obvious thing is obviously the bladder is open to the skin. And again, I hate to, a lot of people talk about, oh, well, is my child going to urinate? Is my child going to do all this? You're going to hear horror stories. You're going to hear great stories about bladder exstrophy patients. But essentially, what we can say is that 50% at the newborn period, we would consider that 50% of the bladders are going to be good bladders. They're gonna grow. They're gonna grow, and they're gonna be able to squeeze, because that's what the bladder really functions is. And unfortunately, 50% of the bladder at the newborn period are not so good, and they're not going to grow, and they're not going to be able to squeeze very well. So unfortunately, there's no real way to tell by looking at the open bladder whether this is going to be a good bladder or a bad bladder. And sometimes it just takes years to figure out, is the bladder going to grow? Is the bladder going to squeeze? But the obvious defect that you see is the open bladder right here, and then the urethra extending down either to the top of the vagina or on the top of the penis, kind of like this. And again, if only the bladder is involved, it would be bladder exstrophy. When the urethra is involved, then it becomes Epispadias also, okay? So, and then this is where the ureters insert right here, and they're connected to our kidneys, like there. So, the bladder, 50% are going to be good bladders, 50% are not going to be so good bladders. There's no urgency to close this. Even 10 years ago, we thought, oh my gosh, we got to get these bladders closed within the first 24, 48 hours. It's going to give the best chance. That's not true anymore. Delayed closure is really becoming the standard of care. So we want you to bond with your child. We want the child to get bigger, more healthy, and all of those issues. So again, there's no rush to anything. You don't have to make decisions. If your surgeon is saying we need to get this closed, I would warn you that maybe we need to get a second opinion. Again, so the Centers of Excellence through the Association of Bladder Exstrophy Community has many different resources. But again, what I tell you is just you got time. Yeah, you definitely have time to think about things to try to educate. Hopefully this app is going to help you through that process. But again, so the bladder, and originally we're going to have to get that bladder closed, and we're going to talk about the surgery to close that. There's essentially two different types of bladder closure, or two different schools of thought, just like there's two different types of cars. There's Fords and there's Chevys and things. So we've got what we call the modern staged repair, and that was really pioneered by Dr. Bob Jeffs and Dr. John Gearhart at Johns Hopkins University. Again, an excellent repair. Thousands of patients have been done this way. The second repair is what we call the complete primary repair. And that was pioneered by Dr. Mike Mitchell when he was at Seattle, Indiana, and then at Seattle. And that's closing up. So he's doing multiple surgeries, on the bladder, the urethra, and the sphincter at the same time. The stage repair, kind of breaks those up over the first 5 years of life. One is not better than the other. The most important thing is that your surgeon has done a lot of them and has good success. Again, the most important thing is get the bladder closed primarily. That will give our chances of having a good growing bladder the best success. Because again, if we don't get a good growing bladder, then the chances of being able to be completely potty trained is less and less. What else is affected in this area? Well, obviously the urethra, okay? So that's this portion that's from where the bladder kind of narrows down and comes out either through the penis or on top of the vagina. So we've got the urethra involved. And that urethra carries the urine out from the bladder on into the, into the diaper. So that's going to have to be rebuilt because, again, all of this is opened up like a book. So, again, the urethra is open, the bladder is open, the penis is kind of split, the clitoris will be split also. We also talk about the sphincter, so that's the muscle that holds our in. That's why I'm sitting here right now and, and don't have any leakage of urine. So, again, we talk about the bladder neck. And some people will also use the term sphincter. Sorry. The word sphincter, to define that. And again, that's just the muscle area that's going to allow us to hold the urine in so the bladder can fill up so the child can, void every couple of hours. If the sphincter isn't working, then the child will leak urine. And again, that little bit of difference. And again, this lecture is not really to compare these two because, again, I think they're very similar. But the bladder neck and sphincter is kind of put together in the complete primary repair with the initial surgery. The modern stage repair, it's delayed, for up to about 5 to 7 years before the sphincter is kind of put back together. So that's just a little bit of difference. There's not much difference, to be honest with you, in the long-term evaluation. There may be some differences in the beginning parts. What else is affected in the bladder exstrophy Epispadias complex? Well, the penis and also the clitoris. Okay, so during the development, the penis will be kind of, and the clitoris will be, separated. So in the penis, the corporal bodies kind of splayed out, are attached to the pubic bone, and the penis will kind of look like that, where it's kind of, and then the urethra is again open, down this way to the bladder, to the open bladder. So all this is going to have to be put back together. And again, we would try to put the penis back together so that it'll stick out and not be flat. In terms of the clitoris, for the clitoris, so this is the penis here. In terms of the clitoris, what we have is usually we'll have the clitoris be completely separate, and you'll have half the clitoris on the pubic bone, and then this half of the clitoris will be on that pubic bone. So for the female, and then the vagina kind of sits right in between there. So for a female baby, we have to put this back together, and again, we will reapproximate the clitoris back together and kind of put the head of the clitoris back together just below the urethra when we build that urethra up underneath the clitoris. So again, both the penis and clitoris are involved. The nerves are normal. Parents always say, oh my gosh, is my child going to have erections? Is my child going to be able to have orgasm? The answer is absolutely, as long as nothing is done to injure these during the surgical repair. But the nerves and everything should be normal, in this situation. So we would like, these to be put back together so that they will function normally with erections and orgasms in the future. The other areas that are going to be involved in here is the kidneys. And again, the kidneys are typically normal with bladder exstrophy and Epispadias, but they need to be monitored. Anytime we start closing up and creating resistance in this, there's a risk for urinary tract infections. Their urinary tract infections could potentially cause kidney damage, but they need to be closely watched for the entire life of the child until adulthood to make sure that the kidneys remain normal. What else does affect the ureters? So the ureters are the tubes that connect the bladder. So these are the ureter tubes. They connect the kidneys to the bladder. And typically they will have reflux 100% of the time. Reflux is when urine goes back up to the kidneys, and it can lead to urinary tract infections and other problems. This reflux will eventually have to be addressed in one of the surgical repairs. What else do we have? We have the pubic bone. So the pubic bone is not necessarily involved in the bladder, but it's open. Remember, the pubic bone should have been the pelvis is a completely circle. And again, the pubic bone in the exstrophy patients are pulled apart. They're not really going to affect any walking or any type of running or any type of athletic activities. But in order to get this bladder closed and the penis and the clitoris and the urethra and everything put back together, we want that to come closer together. So think of the pubic bone as a horseshoe, okay? And it's open, and the bladder and everything is kind of sitting on the top there. So we're going to put the bladder down into the pelvis. We're going to have to then break the pubic bone. The orthopedic surgeons will come in the original surgery, and they'll break the bone. And then that will allow the pubic bone to come back to the center when the bladder and urethra and everything drops down. That will require a cast or some type of traction. Just like if you break a bone, you got to put it in a cast for a while. And there's several different techniques that's going to hold that bone together while it heals. So all of these issues are going to have to be addressed surgically, and whether you do it in the original surgery, there's going to be several surgeries that exstrophy patients are going to require through the years. And this is just a introduction so that you can ask, about these individual organ systems. If you have any questions, you're more than welcome to reach out to me on the website or on the app site. Call me if you want. My team is well versed in understanding all of this. Again, the goal is that you can start to learn the terminology. This is all new to you. We've been involved in working with it for decades, and our job is to help you understand it better. So thanks so much. Hope to see you in the future.